everyone, Assalamu alaikum. Welcome to my channel. My name is أسأل and I'm an RT student. As you all know, I make interviews with respiratory therapists who influence a lot of people in the respiratory therapy field. The goal here is to help the RT students get inspired and learn from the guest knowledge and experience. I posted a question in all my social media accounts. I asked if anyone has any question about the mechanical ventilation. A lot of students send me their questions, and I want to thank you all for that. We will go through them all today, inshallah, and hopefully you won't be having the same difficulty or confusion anymore. But before we begin, I want to let you know, if you did not hear your question, please pay attention to the other questions. One of the questions may be similar to your question, but I rephrase them to be one question, so I won't be repeating the same question over and over. Today, I am delighted to interview a special guest. I am a huge fan of him. His name is Joe Lewis from Fort Worth, Texas, United States. He has been a registered respiratory therapist for 20 years and a full-time educator for 10 years. His area of expertise began adult trauma and ER medicine. So thank you for giving us the time and opportunity to learn from your experience and knowledge.
No, thank you for allowing me to be a part of this opportunity and this experience. I think you're doing a great thing here, and I just hope that the information I share here today can go out and aid the future respiratory therapist in providing a greater level of quality care to our patients.
Okay, so the questions will be in 4 parts. The first part will be about general questions. Second part will be about the MV modes. The third part will be about the MV settings. And the fourth part will be about the MV waveforms. Are you ready?
Yes, ma'am. Let's roll.
Starting with the general question, the first question here we have, if you go back in time where you had to choose what major you want to get in, would you choose to be an RT and why?
So the obvious answer to this question is, of course I would. If I could go back in time, obviously I have the knowledge from this life that I could go back and I would do it all over again. The crazy thing is that typically when we start, we stumble into it not really knowing what we were getting into. And then it turns out to be maybe one of the greatest things that's ever happened to you from a career standpoint. But just the life that respiratory therapy has granted me, the amount of patients and friends and coworkers that I've been able to work with, helping taking care of patients, the trauma patients that I've had the privilege of caring for, and then to see them walk back into the hospital 9 months or 10 months later is all worth it. It's a very fulfilling career that I would definitely pursue again if I could go back in time.
The second question we have here is, as a professional respiratory therapist, what are the advices the student needs to follow to be good at mechanical ventilation?
So a couple of points here. First of all, you have to know what you're doing. You have to understand the modes of mechanical ventilation. You have to understand how pressure and volume are related to one another. And you have to know all the ins and outs and the details of the mechanical ventilator. So not just the modes, but the settings, what varies, what are set. You have to understand what a trigger is, what a cycle is. So the different terminology that comes along with mechanical ventilation. So pretty much what I'm saying is you have to know it all to be good at mechanical ventilation. But here's the best advice I can give you. When you're taking care of a patient, the patient's on a mechanical ventilator, make the ventilator breathe like the patient. Don't expect the patient to breathe like the ventilator. It's always going to lead to asynchrony. Your patient is not going to be happy because you say, well, we want you to breathe this fast with this tight of volume, but the patient's laying there in bed suffering because they're wanting to breathe different than what the machine is allowing them to do. So try to make the ventilator breathe like the patient. You'll have much better outcomes with it.
Wow, that's totally true. Okay, so we're moving on to the next part, which is mechanical ventilation modes. A student is asking, how can I know what is the best mode to use?
So here's my response to this question, because I get asked this question all of the time. And the best response to this question is there is no best mode to use. The question you should be asking is this: how do I know what is the best mode to use for my particular patient? You see, every patient is different. Therefore, what's best for one patient is going to be completely different, than for another patient. And so when you're talking about best mode, there's not one. It's a best mode for that patient. So somebody who comes in with, let's say they have emphysema and they have extensive blebs. Well, you're worried about barotrauma with that patient because you don't want to cause a pneumothorax because the peak pressures get too high. So you would use some sort of pressure control mode of ventilation on that patient. Let's say you had a patient who had a big like bilateral pneumonia and they had a big shunt and you were having a hard time oxygenating. Well, you would maybe want to go to a mode where you could control mean airway pressure a little better than say somebody who's hypercapnic and they just need a mandatory minute ventilation where you're going more volume. So you just kind of have to ask your patients, ask yourself what your patients look like and what does it tell you, If you're in volume control and your peak pressures are 60, similar as water pressure, you need to get in a different mode. You can't sit there and ventilate your patient like that. So, trust your assessment skills, and your assessment skills and proper assessment of your patient will bring you to the right mode you're looking for.
The second question we have here is, a student is asking, what are the medical conditions that should be on a VC and what should be on a PC? In other words, how to determine which mode the patient should be on.
I think when you're talking about volume control versus pressure control, you have to understand what those modes, the benefits of those modes versus the hazards that come with those modes. So let's just talk about volume control. When you have a patient in volume control, you are able to set and sustain a minimum minute ventilation. This is going to be responsible for removal of CO2. So it doesn't matter what happens to your patient's compliance, your minute ventilation is set. That's a benefit. So you don't have to worry about your patient's minute ventilation going down to a dangerous level because your minute ventilation is established. So if you're on a tidal volume of 400 and a rate of 20, then you have a minute ventilation of 8 liters per minute. And that won't change with the change in compliance when you're in volume control. But what happens is when your compliance changes, you will see a variance in your pressures. So if your lungs become very, very stiff, let's say your patient develops ARDS and you're in volume control, then your minute ventilation is still set, but your peak inspiratory pressure is now going to elevate and go very, very high. And as we know, when we put increased pressures in the lungs, as they climb higher and higher, then we put our patient at an increased risk for barotrauma. And so you want to watch out, I think, and assess your patient for barotrauma when you're in volume control. Now, the exact opposite is true when you're in pressure control. You set and you control the pressure, so you're not really worried so much about barotrauma in the pressure control mode unless you just completely screw the settings up. But with the proper settings, you're going to control the amount of pressure that's actually being delivered to the lungs. So you're not really worried about barotrauma. You're more concerned about variances in your minute ventilation. So as your lungs become stiffer, your tidal volumes will go down. As your tidal volumes go down, your minute ventilation goes down. As minute ventilation goes down, CO2 goes up. pH goes down. So you could have a patient whose lungs become very, very stiff. And because you failed to monitor tidal volumes, they are now acidotic because the mechanical ventilator doing its job in pressure control does not provide for a mandatory minute ventilation. So you just got to know what you're doing. Your patient will tell you, what are you more concerned with? You more concerned with having a set minute ventilation, or are you more concerned with controlling pressures? And then just know what varies.
This one is a heavy question, actually. A student is asking, can you please give us a brief explanation on APRV mode, and how can I, as a student, learn it in a way I won't be able to get confused anymore? What do you think?
Okay, so the question here was, can I explain APRV so that it'll make sense to me? Okay, so here's a simple breakdown of APRV. Now, to really get good at APRV, you have to work with it a lot to get really comfortable with it and to really kind of start to see how it functions, how it can improve your chest x-ray and improve your gas exchange and things like that. So you just have to practice. That's the first thing. But here are my top 3 points about APRV that you need to understand. Okay, so I'm going to draw a waveform here, and this is the pressure waveform. Okay, and so we know that pressure rises and holds and then drops and then comes right back up. Okay, so I'm just going to draw this right here. Just 2 breaths. Okay, now the first thing we see is that by holding at this peak high, that's what this is. This is peak high, and we set this is peak low. So those are what we're setting. How long do you want to hold at this pressure, or what do you want this pressure to be, and what do you want the low pressure to be? So that's the first thing we're doing there. Then we're going to tell it how long to hold it. So from here to here is going to be our time high. And then down here, this little section right here is controlled by time low. Okay? Now, what I want you to recognize is that the first thing that APRV does, and the reason it's such a good mode for oxygenation, is because it increases your mean airway pressure. Okay? This is where we see an increase in our map because we're holding at this high peak for so long and barely ever going back to low peak. Just very briefly, falling and then rising. So the first thing it does is, number 1, is increase mean airway pressure. Very, very effectively. If you increase your mean airway pressure, you'll improve collateral ventilation through the pores of Cone, the channels of Martin, and the canals of Lambert. If you do that, you'll recruit more functional alveoli. If you do that, you'll increase your FRC. And if you increase FRC, you improve oxygenation. So that's number 1 that you need to understand. Improves mean airway pressure. Okay? Now, the other thing is what happens, so when we're at this high pressure here, we're improving oxygenation. But how do we ventilate? Well, this drop right here, I'm going to draw another over here. This drop right here is what we call a pressure drop, and that pressure drop is for bulk CO2 removal. That's the second point you want to remember here. Bulk CO2 removal, which means when we get this drop here, we get a large exhalation, a large volume of exhaled gas, and you get a lot of CO2 removal with that one drop. Okay, so these drops can help you control your ventilation side of things, your CO2 management. So if you have a patient, APRV, and their oxygenation looks good or it's getting better, but you find yourself in a state of respiratory acidosis and you think, I need to get rid of more CO2. How do I do it? Well, you just need to add more drops. The same way you would if you were in volume control, you would add more breaths. You would increase your rate. Think about these drops as rates, as a breath. And so you just have to increase the rate of your drops. So you need to put an extra 1 or 2 drops in, and that'll help get rid of CO2. Now, the patient is also breathing spontaneously throughout this entire phase. Okay, so the patient is also spontaneously removing CO2. But that's not the only method. So don't forget the drops equal bulk CO2 removal. And then the last thing is how do we know what time, how to set this little drop right here? So we have our peak high and our time high. How do we know what to put our time low at? And the answer is you have to look at your flow waveform, and you're going to see something that looks like this. And then it's going to drop, and then it comes back. Okay, now it typically comes all the way back to baseline. When it gets back to baseline, all the gas has left the patient's alveoli. Remember, on your flow waveform, if this does not return to baseline, you are air trapping. So watch what we're going to do here. I'm going to erase this. You are going to assess this peak expiratory flow rate, and you're going to trap about 50 to 75% of it. Okay? So you want your time low to trap so that your exhalation happens, and then catch it right about there, and then start the next breath. So that this never returns to baseline. This is point number 3. So point number 3 is intentional air trapping. That's number 3. We're going to intentionally air trap with our time low, our very brief time low, so that we don't have resulting atelectasis. We're going to spend all this time up here at the increased mean airway pressure recruiting alveoli. The last thing we want to do is to, during these drops, to drag them out so that this flow comes back to baseline, and then we have complete alveolar emptying because our pressure low is set at 0. And so they typically set the peak low at 0, but we do so knowing we are going to intentionally air trap right here. We're not going to let that flow. So you'll really only see your pressure fall. Let's say you're on a peak high of 22 and a peak low of 0. You may only get to a peak low of 6 when you're really looking at your graphics. Okay? So that's how you know how to set your time low. So let me recap real quick. Mean airway pressure helps to aid oxygenation. The drops are to serve as a purpose of a bulk CO2 removal. And then we have intentional air trapping, which is why we have our peak low set at 0, and that tells us how to set our time low. Okay? Hey, you got to practice it, study it, stay into it, and just work at learning it, and you'll get it, I promise. Okay? Send me any questions you may have about it.
Another student is asking, I'm having a hard time understanding the ASV mode. If possible, can you explain the mode and why it's not used much compared to the other modes of ventilation?
Well, I cannot answer the second part of this question because I do not know why it's not used much compared to other modes of mechanical ventilation. My guess is probably that it's in regards to modes of mechanical ventilation, it's a fairly newer mode, which means that respiratory therapy therapists and the respiratory therapy world haven't gotten familiar with it and comfortable with it. That's my first thought on that. But why it's not chosen very often, it's probably because it's new and it would cause it requires a change in mindset and approach. Now, what it actually is, first of all, it's a closed looped form of ventilation. Now, this is important to understand because when we talk about assist control or SIMV, or you talk about pressure control, when you talk about other modes of even pressure support ventilation, when you talk about those modes of ventilation, those are open loop forms or open loop modes of mechanical ventilation. Now, this is important because what open loop means is that we tell the vent to do something, and the vent does it. It doesn't matter what happens on the patient's side. If you tell it to give X amount of tidal volume, then it delivers that tidal volume however often you tell it to deliver it, and it delivers it at whatever flow rate you tell it to deliver it at. That's an open loop. It doesn't change based off of patient condition. Closed loop ventilation are modes of mechanical ventilation that actually respond to the feedback they get back from the patient. So things such as PRVC. So PRVC, you have the ventilator gives a pressure breath and then it evaluates the return volume and it says, did the return volume meet? Is it what we're trying to achieve based off of the set target tidal volume? Or do we need to increase the pressure to get a larger tidal volume? Or do we need to decrease pressure? So the vent actually makes changes based off of the feedback from the patient. ASV, which stands for Adaptive Support Ventilation, is a closed loop form of mechanical ventilation. Now, to understand how it works, you need to understand that it's going to use pressure control, and it's going to adjust pressure control ventilation to ensure that a tidal volume is appropriate based off the patient's ideal body weight and sex. And then you're going to set a rate range. And these two things together establish a minute volume. Now, if the patient is breathing spontaneously, then the vent will allow the patient to sustain and meet what you tell the vent is an acceptable minute ventilation. So you tell the vent basically what percent of the minute ventilation do you want the vent to provide for the patient. If you say 100%, then the vent is going to calculate an ideal body weight, rate, establish a minute ventilation, and it's going to make sure that that minute ventilation is being delivered. It'll do so in SIMV pressure control type ventilation and adjust based off of return volumes. Now, if the patient is breathing spontaneously, then the vent will cut back on what it's doing and allow the patient to maintain that minute volume themselves through pressure support ventilation. So in a sense, trying to keep this brief here, in a sense, it's the smart mode of mechanical ventilation that will allow the patient to breathe spontaneously if it wants to. If the patient goes apneic, the vent will kick back in and provide full 100% mechanical ventilatory support in that case also. Okay, kind of a tough subject to do over a voice, but essentially that's how ASV works. Open loop is the key. It makes adjustments based off the feedback from the patient. So I hope that helps. I hope it's helped, and I hope I answered your question satisfactorily.
Another student is asking, can you please explain the SIMV mode?
Yes, I can. So SIMV is a type of mechanical ventilation mode that can either be volume or pressure controlled. And there's the key thing you need to understand. SIMV does not specify if it's volume or if it's pressure. SIMV only tells you how the patient can breathe in between the mechanical ventilators giving the breaths. So if you think about this, you have a patient on SIMV with a rate of 10. They're going to get a breath from the mechanical ventilator every 6 seconds. That may be a volume breath. That may be a pressure breath. That doesn't matter. What SIMV says is that in between those 6 seconds, which is when the ventilator is going to be delivering a mechanical breath, in between those 6 seconds, the patient has the ability to take a spontaneous breath. Okay, this means that let's say you're in SIMV volume control. Every 6 seconds, you're on a rate of 10. Every 6 seconds, you have a tidal volume of 500 being delivered. Well, in between those 10 breaths that minute, the patient can take a tidal volume of 800 if they want to. The patient may want to take a tidal volume of 200. It doesn't matter. The patient can breathe spontaneously however they want. They can breathe also however often they want to in between the mechanical breaths. Now, what happens is you have to understand what SIMV stands for, and it stands for synchronized intermittent mechanical ventilation. Now, the word synchronized here is very important because while the patient can breathe spontaneously in between the mechanical breaths, if they try to take a breath in a very small window or time frame, when the vent is about to deliver a mechanical breath, then the ventilator will just synchronize with the patient's effort and a mechanical breath will be delivered. And so that's why it's called synchronized. This is different than what we know as assist control. In assist control, the vent delivers the breaths. If the patient wants a breath in between the delivered breaths, the patient can ask for a breath, but then the ventilator delivers the breath, the set tidal volume at the set flow. So the patient cannot vary their own tidal volume. They can't breathe truly spontaneously like they can in SIMV.
A student is asking, when should we use a pressure support with dual control modes?
When we're talking dual control mode, you're talking about, I'm assuming you're talking about modes that allow for spontaneous breathing and mechanical ventilation happening. So such as SIMV, you have the vent who's going to give their breaths at the scheduled time trigger based off of the total cycle time. But then you have the patient breathing spontaneously. Anytime you have a patient who can truly breathe spontaneously, they should have pressure support dialed in at least to a minimum level that helps to overcome the resistance of the airway and the tubing and the circuitry, and then larger amounts of pressure support if the need to increase the spontaneous tidal volume is present. Okay, so that kind of explains when you should use pressure support in conjunction with other modes of mechanical ventilation.
Another student here is asking, if the patient was set on assist control ventilation, what should I choose for him, a pressure control or a volume control? And it depends on what?
Well, this is a question that we can go around and around on, but truly what it comes down to is you have to understand the advantages of each mode and the disadvantages of each mode. So here's what it comes down to. When you talk about pressure control, your advantage for pressure control is that you can ventilate your patients at safe pressures. You don't necessarily worry as much about barotrauma because your pressures are controlled. Now, the downside to that is that your volume in pressure control is allowed to vary. So you'll have varying tidal volumes based off of patient's lung compliance, which will cause your minute volume to vary based off of your patient's lung compliance. So in pressure control, because the pressures are controlled, barotrauma is not usually a big concern if you have your settings appropriate. But your blood gases can vary. Your level of ventilation can go up or down depending on your patient's lung compliance. So that's with pressure control. Now with volume control, it's the exact opposite. With volume control, you're at a much higher rate of causing barotrauma because the vent is going to deliver the set tidal volume, even if you have it set incorrectly, which could cause increasing pressure at the level of the alveoli, and it could cause damage and barotrauma. So your pressures could get out of control based off of your lung compliance. Whereas your minute ventilation is set. So you have a set rate, you have a set tidal volume, which gives you a set minute ventilation. And so from that perspective, you'll probably have less fluctuations in your blood gas, yet you'll have greater fluctuations in your pressures that are happening inside the patient's lungs. So that's kind of what it comes down to. Are you more concerned with controlling pressures and preventing barotrauma, or are you more concerned with establishing and maintaining an optimal minute ventilation, which leads to, better blood gas results? And that's going to vary per patient. And so that's why I say there is no best mode. It's what's best for this patient. Those are the pros and cons of each mode that you have to weigh.
So the other question here I have is a bit long. A student is asking, in my clinical rotation, they usually tell me that a COPD patient should not be intubated on a mechanical ventilation unless it is a severe case. Instead, they should be on a non-invasive ventilator. The question here for you is, why is that? And what is the best mode for a COPD patient in your opinion?
I think it depends specifically on the COPD patient. If you have a COPD patient with a lot of blebs, then pressure control is probably going to be the better mode because you can control pressure and prevent barotrauma and prevent a pneumothorax from happening. It doesn't mean it's always the best mode, but typically because COPDers' lungs are so compliant, you worry about pneumothoraxes with the presence of blebs. So pressure control is a safe mode. I think monitoring the patient is the best thing, and no matter what mode you're in. So I'm not saying you can't use volume mode. I'm just telling you to be mindful of those chances for pneumothorax with blebs. Now, why is it that we don't want to put them on a ventilator? Well, here's the deal. COPDers and emphysomatics and chronic bronchitic patients, we understand that they have a hard time breathing. They work hard every single day to get the air out of their lungs so they can get a fresh breath in. And even in doing so, they usually live at levels with higher CO2s and levels with lower oxygen levels, right? So that makes sense. Now, if you take a patient who on a daily basis has an increased effort to breathe and you put them on a mechanical ventilator, then you run the risk of two things. One, it becomes very easy for this patient and they go, oh my gosh, it hasn't been this easy for me to breathe in a long time. And they've become very, very difficult to wean off of the mechanical ventilator. And so a lot of times they may end up being trached, which, even compounds the problem from them trying to breathe, because now they can no longer pursely breathe. So they lose the upper airway anatomy, which reduces resistance, which, means that they're just going to air trap even more. Now, the other thing is that a lot of times when we put a COPD on a ventilator, what we'll do is we'll mismanage the ventilator. So COPD comes in and they have a high CO2 and a high bicarb. Well, they live at those levels with those high bicarbs and those high CO2s. We sometimes mistakenly do, which you have to be better than this. You just have to recognize and understand that this is not what to do. But what we sometimes do is we normalize the COPDers' CO2 levels. And in doing so, they become alkalotic from the excessive bicarb now. As that's the case, their bicarb will start to decrease. Well, as soon as you take them off the vent, their CO2 is going to go back up. But now they have lost the compensatory mechanism because their bicarb has come down while they were on the vent. And so it has to do with mismanagement and understanding that when you have a COPDer that comes in with a CO2 of 90, you do not blow that CO2 down to 40. You blow the CO2 down to whatever level brings the pH back to 7.35, and you leave it right there. If it's 75, that's where they live. So let them stay right there. Otherwise, you're going to have a very difficult time getting them off the vent, just like you said, you've heard about and seen in your clinical rotations.
All right then, so we answered the first parts, which are the general questions and the MV modes. We will be answering the MV settings and the MV waveforms in the next video.